All right, everybody thoroughly asleep after lunch and a long day? All right, so the goal with this is to kind of discuss the next steps of diagnosis and monitoring of bone infection. And so we'll get into that a little bit here. No disclosures. So what's the problem that we're dealing with? You know, we all know that diabetic foot osteomyelitis is costly. It can be devastating. And it's important to be accurate in our diagnosis. And that helps guide our treatment. You know, what do we use for this? What about recurrences? You know, when we talk to our other colleagues in the hospital, you know, how many times you get asked, oh, well, I don't know, what about this? The MRI's this, or the labs are this. And if it comes down to it, you know, you can probably find a paper that says just about anything. So, you know, what is a biomarker? You know, it's a lot more broad than you think. You hear biomarker, you know, I think a lot of people think labs, blood work. You know, it's an indicator of a biological state or condition. It can be molecular or cellular, it can be physiologic, it can be clinical findings, histologic, radiographic, and we'll take a look at all of these. Like I said, what can we use? You know, we see probe to bone here. You know, we see vials for labs. You know, broadly, it's about anything that you can observe with a patient. What can we put together to get this answer? And if you're lucky, like in this case, the patient comes in with arrows stuck in their foot, and it's pretty obvious. And when you look at the literature, especially when you look outside of podiatry, when you look outside of the realm of surgery, you start seeing many different reference standards used. You see people will say just clinical findings, probe to bone. You see radiographs. You'll see people talk about labs. And once again, like the previous talks today, it's really important to know your patient population. Speaking of probe to bone, you know, here's the original. Here's what everyone likes to cite, Grayson and Gibbons' paper. But once again, it's important to know your patient population. These are all infected patients. You have a high pretest probability, and this is where people say, oh, it probes the bone, it's definitely infected. But that's not always the case. You know, Dr. Lavery referenced this earlier. This is an excellent paper, much larger study, 1,666 patients. And what's really nice about this is he looked at all wounds and he looked at the infected wounds. And especially when you look at all wounds, all comers, you know, your patient who comes into your office, where probe to bone comes in handy is its negative predictive value. If you look at that here, it's 0.98. It's pretty good. You know, you can see quite the difference. If it probes bone in clinic, you know, 0.57 versus Grayson and Gibbons' paper, you know, it's very different patients and situations. So it's, you know, the things that we're taught in school are not necessarily things that we can hang our hat on in diagnosis for treatment of this and planning it. You know, how can we be confident? You know, you can be pulling out bone chunks like here and have your hemostat go through the foot and through the bone, and you know, you get those slam dunk cases, but it's not that way all the time. You know, like I said, when you have a high negative pretest probability, when you're high negative predictive value when your pretest probability is low. Not like this patient. All right, what about imaging? So if you look at once again, going to the International Working Group, especially this year, the infection guidelines were co-written by the Infectious Disease Society of America and the International Working Group, which I'm glad they did that because the previous versions were basically written by the same people anyway. And they recommend using MRI to diagnose this. It has good sensitivity and specificity. And if you look at the radiology literature, some of the musculoskeletal radiologists are advocating for using MRI as the reference standard. There's a big problem with that, though, is that you don't get cultures, you don't get your sensitivities, and we know how important that is. Depending on who you have helping you read your report, read your studies, there can be concerns for false positives. You know, we're lucky where we're at. We have fellowship-trained musculoskeletal radiologists that do a really nice job of teasing these out, but that's not available everywhere. And we all know this. This This is what, it's on every test. What's the gold standard? Well, it's getting a bone biopsy. And what is that? So, okay, you get your piece of bone, you send it to the lab. Is it positive culture? Is it positive histology? Is it both? Is it something else? And, what do the guidelines say? Well, it's a little soft. They say that basically it's nice if they're both positive or they're both negative, but how many times do you get this and they don't agree? You get one's positive, one's negative. ID comes to you and says, what'd you see? What do you think? I don't know. And then you hear the famous line, well, we're just going to do the safe thing and we're going to treat them. But just treating everybody is not necessarily the safe thing. There's a lot of negative side effects with unnecessary treatment. But as we all see, community practice, a positive culture or path is probably buying your patient 6 weeks of treatment. So what is the optimal operational definition of this? Well, a benefit of that would be uniform practice, which would help improve outcomes theoretically, which would reduce complications and side effect and potentially cost. The golden goose. So we looked at this. We looked at messing around with the operational definition in a group of patients who all had bone biopsies. And depending on how you interpreted it, you got a wide-ranging number of positives or negatives for your diagnosis. We looked at using 16S genetic sequencing, that's been talked about some today, traditional culture, histology, and then combinations of both using recommended diagnostic criteria. As you can see here, depending on how you interpret that, you can change your diagnosis rate by almost 40%. That's almost a coin flip in changing your diagnosis. And that means a lot of different change for your patient, what they're going to go through the next several weeks. So what does this mean? Why is this so important to get this down? Well, underdiagnosing your patient, you're going to miss the bone infection. That's what we all don't want to do. We don't want to miss anything. Chance of unchecked infection, higher level amputations. But then overdiagnosing is not safe either. I said earlier, we all hear that I'm just going to do the safe thing anyway. Well, we showed in a recent paper that patients who are treated for osteomyelitis have AKI almost 50% of the time. The only thing worse than that is sepsis in the ICU. It pushes them through their CKD stages. It's expensive. And there's complications. 20% of these patients get a line complication. So what do we do with this? How do we monitor it? You might get your diagnosis. What do you do next? So you might think, what do you do in your practice? When we have trainees come through, it's a smattering. There's no generally accepted practice of how to monitor. Like Dr. Lavery said earlier, right now people get their 6 weeks, they get a pat on the head and say, well, good luck. There's really not any kind of follow-up. And that's because we're still using recommendations, guidelines from animal studies in the 60s to treat this. So most of the time, as you see and I see, it's based off clinical picture. Well, you see the ID note, if you're lucky enough to have ID, and they say, well, wound's healed, foot looks good, no redness, looks great. Sometimes you'll see them following labs, especially if you have ID following your patient. And then sometimes you'll check for imaging, but it's not always the case. So we look at monitoring. There are some papers that looked at using labs for monitoring for recurrence. This one by Lynn, this is in Journal of Orthopedic Surgery. And once again, this is not really our patient population. This is an all-comers, all sites, different ways of getting bone infection. And as you can see, what they find out doesn't really match up with our patients. They've said an ESR over 20 can be a risk factor of recurrence. Well, if our patients sneeze, their ESR goes over 20. And if they have kidney disease, it's almost always over that. Having MRSA was an independent risk factor. And surprise, lower extremity. All right, what else? Once again, Dr. Lavery's group with Suzanne Van Asten, they looked at this. This is a small 35-patient pilot study. It had some pretty interesting findings, not just looking at diagnosis, but monitoring for bone infection through treatment. And they looked at SED rate and CRP, like most of us use. procalcitonin. Then they looked at IL-6, IL-8, MCP-1. And if you're like me, some of these, when I first read it, it's like, what's MCP-1? But this is a very busy slide. But what I want to bring out here is showing that they looked at values at baseline, at 3 weeks, and then at 6 weeks. So at the end of treatment. And what do they see? Well, if you look, basically the stuff that worked out was in the diabetic foot osteomyelitis group, not so much with the non-diabetic foot group. But we see that CRP, SED rate, procalcitonin, and IL-6, as well as MCP-1, had some signal. Small study, but this is pretty interesting. You know, this might be another way to monitor these patients after treatment. Another one looking at procalcitonin was by Reiner. They looked at 175 patients where procalcitonin was drawn before surgery for a foot infection. Nice big study in our patient population. But, you know, procalcitonin was really popular for a while and then it kind of fizzled out. But they were able to see that there was a difference in patients who needed a major amputation versus those who did not in their procalcitonin levels. Villasaris looked at a literature review in 2018 of procalcitonin as a diagnostic and prognostic marker. They had 15 studies with one meta-analysis, and they evaluated procalcitonin for its diagnosis in diabetic foot infections. And what they could glean was that it's helpful in assisting with a diagnosis of infection, but it's not so helpful in minor infections, which probably goes back to we deal with a population with blunted immune responses. This one I'm nice and proud of. One of our recent fellows, Dr. Ansert, along with Dr. Terracone here and Dr. Lavery, did this meta-analysis systematic review looking at these, again, pulling in some more current data. And they're able to find 17 total studies that met criteria for inclusion in the meta-analysis, with ESR having 12 papers, CRP 10, and procalcitonin 6. And that's quite a few subjects, especially for our neck of the woods. And to sum it up here, found a pooled area under the curve for ESR was excellent at 0.83. And I don't know if you're hearing the same things that I hear at my institution, is there's a growing pushback against using SED rate. We know that renal disease impacts it, and a lot of people push back against using it, but paper after paper continues to show that SED rate is beneficial for monitoring in our patients. Saw that CRP and procalcitonin area under the curves were acceptable, and that their minimum diagnostic odds ratios for SED rate, CRP, and procalcitonin were above 1 and potentially useful for discriminating between bone and soft tissue infections. So with all this, there's still really no consensus for monitoring and success. And boy, would it be nice to have a method that could tell us if we were successful, especially when we see rates of reinfection and readmission as high as 50% in the literature. But outside of bone biopsying everybody, everything else is an indirect measure. People heal over infected bone. You can get imaging false positives. They can just be having a bad day. So, okay, what about the classic findings, the one that everyone looks at? Did they heal? Well, we looked at, a few years ago, clinical surrogate markers between patients who had bone infection and not, and it really didn't make a difference. You know, if no difference in ulcer failing to heal within 12 months, reulceration, readmission. The only thing that was significant was that additional surgery after discharge at the same site was higher in the soft tissue patients. So are there better peripheral measures for predicting this? Are they out there? So we looked at some of the same labs as the previous papers, SED rate, CRP, procalcitonin, IL-6, 8, and MCP-1. And with this, we wanted to evaluate if these could identify recurrence of bone infection after an initial treatment for it. All patients receive the same standard of care medical and surgical treatment for their bone infection and their infections, and all bone infections were confirmed by bone biopsy. And some of them with their antibiotics had a nice little IV Christmas tree right next to them. and they all received the same antibiotic protocol. Nothing was interfered with that. Once again, to keep the same timeline, biomarkers are drawn at baseline 3 and 6 weeks. And since this was also small, we use an alpha of 10 to look at getting a signal. 11 patients with a soft tissue infection and 24 patients were found to have osteo, all by bone biopsy. And in follow-up, 9 patients were identified with a new osteomyelitis diagnosis. 5 of those patients were initially diagnosed with soft tissue infection and 6 previously with bone infection. And this is what we found. We found that, once again, SED rate actually came out on top. Reinfection with an average value of 73. And then we had a little bit of signal with CRP, IL-6/8, and MCP1 with no difference in procalcitonin. Now, just because it's significant doesn't mean that you can hang your hat on it. The area under the curves were okay, with IL-8 being the best, and even though SED rate was significant, its area under the curve was only 0.66. And then what we found with these patients is that, as expected, if you had a reinfection, your antibiotic course was longer. You had more amputations after admission, it took you longer to heal, and they had more reulcerations of the same foot. So there is an option. There's a chance. You know, this is an area where we may see some benefit, and it can help guide our treatment of these patients. You know, they're high-risk patients, and we want to avoid the big catastrophic blow-up with a patient in the ED. If we can catch this early and biopsy them in the clinic, we might be able to do an outpatient course to treat their osteomyelitis as opposed to going in for an admission. Thank you very much.